next session. I would like to call upon the next panelist, Dr. Amruta Sindhu, Sashikala Elizabeth, Anil Kumar, Dr. Kalpana Narendran, Dr. Sandra.
Yes, thank you so much. Yeah, we will go ahead and start the next session.
Sure, ma'am.
So myself and Dr. Amrita will be logging in from a single login because we'll be presenting from the same laptop. So all the 4 speakers are here, so we'll start the session.
Sure, ma'am. Thank you.
The session is going to be on a simple approach to essentials in strabismus, a case-based discussion. Strabismus, though thought to be complex, can be made well simplified by a systematic approach. This session intends to deal with the approaching and the management of common strabismus entities by using case-based approach. So we'll be using clinical photos, videos, and flow charts. We'll basically be covering sessions on approach to esotropia in a child, sudden onset of diplopia, approach to vertical strabismus, as well as how to manage shaky eyes. I call upon the first speaker, Dr. Amrita Sindhu. She'll be speaking on approach to acute onset esotropia in a child.
Just before Amrita starts, am I audible? I just wanted to check my audio.
Yes, ma'am. Yes, you're audible.
Okay, thank you. Dr. Amrita will be talking on acute onset esotropias. And yeah, we happen to see quite a few of these in the pandemic. So we will hear now whether there is any relation to the mode of near activity or not. Yeah. Please go ahead, Amrita.
Okay, good evening, everybody. Thank you for that kind introduction. It is indeed a different experience to talk in a virtual platform in a national conference. So for the next few minutes, I'll be talking about how to approach a child with acute onset esotropia. So acute onset esotropia, also called as ACE in short, that means acute acquired committed esotropia. Definitely all of you would have noticed a dramatic rise in incidence during past few years. So so the older reports in various publications shows a incidence of about 0.3%. But in past few years, especially post COVID pandemic, we have seen a dramatic rise in incidence of this ACE. So more so in the Asian countries. So although there are various factors contributing to this increase in incidence, definitely we have to blame this pandemic scenario, because 70% of world student population are now held at home, and they're all attending online classes, which has become a new routine. Added to that, there is definitely a dramatic rise in the incidence of myopia worldwide. So definitely this is also playing a role for this increased incidence of ACE. Added to this, indirect factors can be stress, environmental modification, dietary modification, which can also contribute to this increase in incidence. So there are various recent publications showing that excessive smartphone use and excessive gadget use definitely plays a major role in increased incidence of this ACE. So basically the mechanism, what is happening is because of excess near work due to use of gadgets and smartphones, there is increased amount of accommodation leading on to increased convergence. So because of constant convergence, there is an increased medial rectus tonus, which can manifest into atropia, especially in children who have a very poor fusional reserve or those with a latent esophorias. So how do we approach a child who is presenting with such manifestation in your outpatient department? So usually they'll present with a sudden onset misalignment. Usually in a normal child who was orthotropic previously, this can be confirmed using older photographs which shows orthotropia. Usually to start with, the misalignment will be like intermittent most of the times, which is variable. Every visit you see them, they'll have a different amount of deviation. Most of them, they'll present with diplopia. Diplopia to start with, initially it will be a diplopia for distance followed by a diplopia for both distance and near. Although previous studies says that the presentation is more common in older children and young adolescents, Nowadays, there is no clear-cut age because it is seen in all age groups. And most of the cases, there is no prior neurological or ocular complaints. So when you elicit the history, definitely there will be a history of excessive gadget or smartphone use in most of the cases. There will be a use of gadgets for more than 4 to 6 hours per day. They'll be attending online classes, definitely lockdown, less outdoor play. And most of the cases also we have noticed that there is an uncorrected refractive error, both in the form of myopia as well as hypermetropia. So before moving on to the management part, way back in 1958, Burian and Miller classified A's into 3 major types: type 1, type 2, and type 3. Type 1 is also known as Swan type. Swan type is caused mainly because of prolonged occlusion of one eye, which can lead on to interruption of fusion. So type 2 is also called as Franciscetti type. So here basically there will be a physical or a psychological stress which can lead on to disruption of fusion. And most of these cases will have an uncorrected mild hypermetropia of less than 3 diopters, and most of them will not have an accommodative component. Type 3, which is more commonly seen these days, is Mieszkowski's type, where these cases will have an uncorrected myopia. Usually it is of moderate amount of about -5 or more. So this is the older classification. In the recent past, way back in 2015, there was a classification which was given in Acta Ophthalmologica, where the classification was based on 48 children who presented with A's. They classified A's into basically 7 types. Type 1 is same as Swan type, that is occlusion related A's. Type 2 is idiopathic A's, where there is a non-accommodative component precipitated by stress. Type 3 is an acute accommodative A's, where the refractive error is more than or equal to +3 diopter, and usually it is precipitated by stress. Type 4 is a decompensated A's, where it is most commonly happens post-surgery. Usually there will be a decompensated monofixation leading on to diplopia. Type 5 is a neurological A's, where there is an underlying intracranial pathology. Type 6 is cyclical A's, where there is a tropia and orthotropia and isotropia alternating, and usually it is associated with some non-accommodating hyperopia. Type 7 is a secondary A's, where there is an underlying, the A's manifests post an ocular disorder like optic neuritis. So moving on to the management, first we'll do an orthoptic evaluation. So whenever you do an orthoptic evaluation, you will notice that usually the angle of deviation, some of the kids, it usually starts as a small angle. Most of the time it is intermittent. Some of the kids might present as a large angle comitant isotropia. Rarely it can be cyclical also. So mainly this angle of deviation is very variable. Every visit you will see a different amount of isotropia. Even the isotropia varies during the time of a day also. So always look for the deviation both at distance and near, because most of the time there is a near distance disparity, the deviation being more for distance as compared to that of near. So there will be on binocular vision assessment, there will be a divergence insufficiency. Also look for lateral incompetency, and also lateral incompetency is important because it paves way towards the presence of a small amount of 6 nerve paresis. Also, always confirm the presence of binocularity. This can be done by placing a prism, appropriate prism, and check for the BSV. So this has to be recorded because the management mainly depends on the presence or absence of binocularity. So one of the most important factor in this ACE is neurological ACE, where there will be an underlying neurological disorder. Various studies gives a different incidence varying from 6.4% to 40%. So the most common causes leading on to ACE are Chiari malformations, hydrocephalus, cerebellar lesions, and intracranial tumors. So although the exact mechanism how it happens is not known, commonly it is because of divergence palsy, because of brain stem dysfunctions. It can be because of disruption of supranuclear mesencephalic system, which plays a role in virgin sign movements, or it can be a subtle bilateral sixth nerve paresis, which may not present with abduction deficiency, but can present with only mild incompetency. So in all these cases, you have to keep in mind that myasthenia, which is a great mimicker, can also present. So always rule out myasthenia in all these cases. So some of the warning signs which can point towards the presence of any underlying neurological disorder, don't miss to look for these, such as nystagmus, subtle abduction deficiencies, so greater deviation, that is near distance disparity, and also lateral incompetence. So all cases of acquired acute isotropias, neuroimaging is warranted, because we cannot afford to miss this underlying neurological pathologies. So moving on to the management, management can broadly be classified into general management and specific management. General management, as in case of any strabismus, assess the visual acuity, do a good cycloplegic refraction. So because most of the cases might have myopia or underlying hypermetropia, so give them best corrections. And also in long cases, they might have some degree of amblyopia, which has to be managed with appropriate occlusion therapy. Moving on to the specific management. So specific management can be done in 4 ways: prisms, divergence exercises, botulinum toxin, or surgery, which I'll be discussing in further slides. So before starting any management, definitely you have to explain the parents the major cause of this is excess near work. So refrain from use of excess gadget use. Although I mentioned prisms are not routinely used because of the mechanism of eating up prism phenomena, because every time you give a prism, the deviation goes on increasing and you have to keep on adding extra prisms. So usually prismotherapy is not recommended. So divergence exercise is usually given in the form of Brock strings, which is easy to do. And these divergence exercises can be combined with other mode of therapy. Also, it can be given for small angle deviations in the form of esophorias, or those who are presenting only with intermittent diplopia, more so for distance. Coming to specific management, definitely botulinum toxin plays a major role, because many of the studies have shown that botulinum toxin gives a promising results in these cases. So especially when compared to adults, pediatric age group shows a better results with this botulinum toxin. But the most important thing is you have to select the case which are ideal for botulinum toxin. The ideal case will be within 1 to 2 months of onset of deviation. So those candidates are ideal for botulinum toxin. And they should have a potential for BSV, because only in the presence of BSV the alignment can be maintained post Botox. And also those who are having small to moderate angle, they are ideal for botulinum toxin. Usually botulinum toxin is given between 3 to 5 international units into the medial rectus, about 5 millimeters from the insertion. Either it is given in a GA or under topical anesthesia based on the age. Moving on to surgical correction, surgery usually can be either a bimedial recession or a recess resect procedure. It depends on surgeon's preference. If it is alternating between the 2 eyes, bimedial can be recommended. If there is a different preference for one eye, so, or if there is a presence of amblyopia, recess resect procedure is recommended. So because most of the cases have a very variable angle and some of the cases have very small angle, such cases we can plan for an adjustable sutures also. So the timing, as in any case of paralytic strabismus, usually we have to wait in these cases, because most of the cases initially to start with will have a very variable angle. So wait for the angle to stabilize. Usually about 4 to 6 months after the onset of this misalignment, surgery can be planned. Usually surgery is done for those who are having a very large constant angle, and also those who present very late with a long-standing cases, or if there is an absence of BSV or stereopsis, you can go ahead with the surgical correction. So follow-up is also very important, because you have to do a very close follow-up, because there is a risk of recurrence. Although recurrence is more common in adults, children can also have recurrence. In such cases, we might have to give botulinum toxin, or you might have to add even post-surgery or post-botulinum toxin injection. If there is a small degree of esophoria remaining, it is always better add divergence exercises for such kids to maintain the orthotropic position. So, there is definitely increased incidence of this case during past few years. Although there is no clear standard management protocol, definitely we have to go as a case-based approach. Every case is different. You have to decide what way of management is appropriate for that child. And always not to forget that you have to do a neuroimaging on all cases, because we can never afford to miss an underlying neurological pathology. Thank you.
Thank you very much, Dr. Amrita. It was a very nice and comprehensive presentation. So what I would like to add is that somehow since the onset of the pandemic, we used to see these acute onset esotropias once in a while. But right now it's become quite common since the past year and a half, I would say. And in our follow-up, we have now around 17 to 20 patients who had come within like a month to 3 months since the onset of sudden onset esotropia. So the important thing is to differentiate between the LR paresis. So it is very important to do the gaze measurements and be sure that it is a case of AACE and not a case of even a mild LR paresis. Fundus evaluations and MRI is the same prior to management. The management in very mild cases, if there is diplopia is not constant, then we can give divergence exercises, the Brock string or any other forms. But if the diplopia is constant, as in most of these are children in school-going age group or college students who have a lot of symptoms because of this. So we here in Coimbatore, we are proceeding to give Botox injections as the second line of management. And as she said, we usually inject only in cases where there is diplopia is there and they have binocular vision definitely, and not much of suppression. Because in very young children, the suppression sets in very early, like in by 3 or 4 months in a 4-year-old or 5-year-old, they already go in for suppression. So in those cases, what I have seen is after the Botox injection, the alignment is there for some time, but again, the chance of getting esotropia is quite high. So BSV is important. And right now, we are looking at a 6 months follow-up of all these patients. Quite a few, around 70% of them do fine, but few of them are having recurrences after the duration of Botox is over. That's over 3 to 4 months. And in those patients, we'll be going ahead with the surgical correction as the final line of treatment. So thanks, Amrita. And we'll be proceeding with the second talk by Dr. Sashikala Elizabeth, my colleague. So she'll be talking on an approach to a case of sudden onset diplopia. Yeah, over to Sashikala.
I'm afraid, Dr. Sandra, I cannot see Dr. Sashikala in the meeting. She was there sometime before. Yeah.
Yeah, Dr. Sashikala is logged into the same login as Dr. Amrita. So she's sitting right there.
Right. Okay. Yeah.
Yeah, thank you. They are in the same hall actually.
Okay, sorry.
Thank you.
Thank you. Ma'am, is my slide visible?
No, you have to share screen.
Okay. Just a minute.
You have to stop sharing Amrita's and then yours will be visible.
So just to guide you, ma'am, it should be yes. We are able to see your slide.
Right now, we are able to see.
Right. Okay. Yes. Fine. Thank you so much. At the outset, I would like to thank the scientific committee for giving me this opportunity. My topic will be on approach to a case of sudden onset diplopia. Acute onset diplopia represents Acute onset diplopia represents 0.1% of all the presenting complaints to the emergency room. One needs to recognize it and differentiate it from the benign cause as simple as could be a refractive error, any aberrations that can cause diplopia, from a life-threatening etiology like an aneurysm or a space-occupying lesion. So when you have a patient who presents to the department or to the emergency room with sudden onset of diplopia, the first thing to differentiate is it a monocular or is it a binocular diplopia? So it is as simple, just cover one eye or ask the patient how it is. When they cover one eye, does the diplopia disappear or does it still persist? So if they mean that the diplopia persists, then you are looking into a case of a patient who is presenting with a monocular diplopia. So a simple test to rule out the most common refractive aberration is to do a pinhole test. So refractive aberrations and other detailed slit lamp examination will reveal us the reason why the patient should have a monocular diplopia, starting from corneal problems of irregular cornea, the lens related, or a macular pathology. So when a patient has binocular diplopia, after proceeding to the cover test and measuring a prism cover test, we'll be able to quantify the strabismus and differentiate it from an comitant from an incomitant strabismus. So the most common type among the comitant strabismus, which my previous speaker has spoken about, like isotropias, decompensated, phorias, accommodative ETs, are the more common comitant one, where the primary and the secondary deviation with either eye fixing remains the same. Incomitant deviation, mostly cranial nerve palsies. So when one is at a doubt, can proceed with the postduction test, where you can differentiate if the FTT is positive, you're looking at a patient who has a restrictive strabismus. If the FTT is negative, you're looking at a patient who has a paralytic strabismus. If there is a history of varying symptoms and varying duration, and the deviation also keeps changing when we are measuring, there is ptosis, then we are looking at a neuromuscular junction-related pathology, could be a myasthenia. By doing a tensilon test, one will be able to differentiate it whether it is myasthenia. The rest are rare, so I haven't covered them. So these are the more common ones, and if you've taken a stepwise decision, then you'll be able to fix in what the etiology, possible etiology you're dealing with for the patient. So always follow a stepwise pattern when we're evaluating the patient. History is a more pertinent one. So detailed history about the onset, progression, whether it is intermittent or constant, for us to deal with, whether it is related to a constant pathology of a paralytic strabismus or intermittently changing intermittent exotropia, decompensating phorias, or intermittent symptoms for a myasthenia. Does the patient complain of any varying diplopia with his head position or the gaze change, whether the diplopia becomes better at certain positions, whether there are previous histories, associated neurological complaints, headache, vomiting, then you're looking at something more than an usual one. So you need to be more aware of the neurological symptoms, any history of pain. So onset-wise, if it is a sudden onset or at any age, could be dealing with a paralytic, and if it is gradual and it is present from the childhood, it could be a non-paralytic kind of a symptom. Always go in and review the symptoms, whether other cranial nerves of 2nd, 5th, 7th, 8th, and 9th are involved. So more than one cranial nerve, again, we're dealing with something more than monocranial nerve palsy, like microvascular related reasons, or are we dealing with any other lesions that is causing space occupying or any neurology. So by knowing the multiple cranial nerves, one will be able to localize where the possible lesion could be. The history about diabetic vascular disease, hypertension in an older patient, then we are dealing with a microvascular problem. History of trauma with the difficulty in looking down gaze, then it could be a traumatic fourth nerve. History of muscle fatigueness for myasthenia. History of palpitation, heat sensitivity, weight loss, then we are dealing with the patient probably because of thyroid dysfunction. Any brainstem symptoms focusing to ischemic stroke like vertigo, aphasia, ataxia, dysphagia. If there is difficulty in bowel bladder, maybe we are dealing with the patient. We need to look into other things and evaluate for multiple sclerosis. Medical history, medications, drugs induced should be taken into consideration. Examination, coming on to the ocular motor, do a thorough external evaluation starting from the abnormal head posture. Is there any AHPs, face turn, chin lift, head tilt? Is there any ptosis? Is it a pseudo or a true ptosis or complete ptosis? Or is there any facial asymmetry along with it, any extraocular motility limitation along with the ptosis? How is the globe? Is there a prominence of globe, exophthalmic appearance? Then moving on to the motor evaluation, do a cover test which will help us to reveal any decompensated folius latent strabismus to see for the variation in the movement to differentiate from a primary and a secondary deviation. Do a cover uncover test, prism cover test, and quantify the deviation. Do an extraocular movements and see for which all gaze the limitation and where is the overaction of the muscles. Especially whenever there is a doubt and vision is equal, do a right fixing and left fixing so that we will be able to differentiate a primary and secondary deviation. Park's 3 steps specifically in hypertropias to differentiate what could be and localize a vertical recti or an oblique that is involved. So we, based on which gaze it is increasing, which head tilt it is increasing, which eye is hypertropic, one will be able to localize most of the times if it is a typical oblique or a typical vertical recti being presenting as a mononuclear. Double Maddox rod often helps us in patients who very clearly mention that they have a tilt. So clearly ask them about the positioning of the tilt by comparing it to the side of a door or a window, how the position of the edge appears. Many times by doing a double Maddox rod, one will be able to pick up whether it is a unilateral fourth nerve or a bilateral fourth nerve and quantify the torsion, how we want to manage it. Diplopia head-starting definitely plays a role in a patient with diplopia for us to make out where the gaze of maximum separation is. Always remember that the maximum separation of the two images will be the gaze where the two muscles are acting, and based on whether it is crossed or uncrossed, and based on the position of the second image, one will be able to specify which muscle, specifically denote which muscle is palsied. So the position of the image is the reversal of the position of the eye, and the distal image in vertical deviation always belongs to the paratic eye. His chart helps us for a proper documentation, also helps us to quantify the deviations, look for torsion. Definitely his chart evaluation and documenting in the first visit. When they come for the subsequent visits and documenting it will help us to see whether there is any resolution. His chart definitely will help us in picking up any small paresis. Also, if we don't see any obvious extraocular motility limitation, his chart would help us to pick up any paresis. Coming on to sensory evaluation, Berth 4 dot is a standard method, helps us to clearly denote whether it is crossed, uncrossed, vertical, horizontal diplopia that we're dealing with. Begelini's glass will help us to differentiate whether it is we are dealing with any retinal correspondence ARC, whether we are having the patient with scotomas, suppression scotomas. So to recollect, paralytic strabismus, definitely secondary deviation will be more than the primary, and in non-paralytic, secondary and primary will be the same. And ocular motility will be limited with paratic, non-paratic ocular motility will be full. So specific tests, postduction test could be done as an outpatient department in your office also. Plus, just before you start any surgeries, it is mandatory for a person to do a postduction test. So in a patient in an outpatient department, so after application of topical anesthetic medication, use forceps, atraumatic forceps, hold the conjunctiva. So grasp the globe and push the globe towards the direction where there is limitation of the movement. So if a person succeeds in moving the eye in the direction of limitation, that means the FTT is negative. That means there is no restriction on the opposite side. If the person is not able to move the eye in the direction of limitation, then postduction test is positive. That means we are dealing with a restrictive pathology. Similarly, on table, we can perform a exaggerated postduction oblique traction for the obliques as well to quantify any laxity of the tendon. So force generation is the point beyond which the person can move. This is the patient, it is not the voluntary movement by the examiner, it is the direction the patient has to move beyond the direction where the extraocular motility limitation is present. It can be quantified as well. So to remember, FTT negative means the eye can be moved further. So we are dealing with the patient with palsy or paresis. If FTT is positive, that means we are not able to move the eye further. We are dealing with a restriction pathology. Of course, visual acuity estimation and documentation is very essential because multiple cranial nerve palsy, sometimes you'll be dealing with a patient who has second nerve also involved. So quantifying and regular visits, quantifying the vision is mandatory. Looking at the pupil is also plays a major role, especially in third cranial nerve palsies, where pupillary involvement and non-pupillary involvement, the management and the investigations would differ. So fundus examination, one should have look in for other fundus pathology which can result in double vision, also look for the torsion of, to see for any pre-existing excyclotorsion, specifically when we are dealing with a patient with a fourth cranial nerve palsies. So do a thorough general and a neurological evaluation whenever required. Always take in a consult from a neurologist or a dietitian, endocrinologist whenever you have doubt in, and systemic evaluation whenever it is required. Other ancillary tests would involve, as I told in the first slides, about tensilon test, hydrophonium injections, or testing for myasthenia, or sending for antibodies for cholinesterase, doing a thyroid function test, T3, T4, TSH. In case of suspecting myasthenia, do a repeat nerve stimulation or EMG. Whenever we're dealing with a patient more than 60 years of age and you're suspecting arthritic end, do a detailed blood investigations, complete blood counts, C-reactive protein, ESR, we're thinking of a giant cell arthritis. Often we are left with the decision making whether this patient has to be imaged or can we wait and watch. So unenhanced plain CT is not useful for us to come to any conclusion. MRI is usually preferable in any case for oculomotor nerve palsies. For any patient who are dealing with an acute isolated third nerve palsy, should be imaged with CT and CT angiography whenever you are suspecting a compressive aneurysm, because the most common posterior communicating artery and the junction with the internal carotid artery is the most common site where the aneurysm patient can be presenting with an acute isolated third nerve palsy, pupil involving. When you're suspecting orbital apex syndrome or retroorbital mass, thyroid related or orbital trauma, plan a contrast enhanced CT imaging for the brain and the orbit. When you're suspecting cavernous sinus thrombosis, preferable is to do a CT and a CT venogram. Young patients, non-traumatic, nil systemic illness, when they present with double vision, they're suspecting much beyond the monocranial nerve palsies, go in for an MRI with contrast. Children with bilateral presentations of cranial nerve palsies or acute or recurrent, whenever suspicious symptoms are there, neurological pictures are there, go in for an MRI with contrast, do not delay. So to recap, differentiate from mononuclear to monoocular diplopia to binocular diplopia. When you have neurological symptoms, have a neurologist consult, go in for imaging. Isolated palsies, do a detailed orthotic evaluation, differentiate which cranial nerve or multiple cranial nerve and decide on the imaging. When you have an older patient, decide in and go for blood investigations to see for giant cell arthritis. The most common neurological, congenital, traumatic, and ischemic, and most common myogenic origin could be myasthenia and orbital thyroid-related myopathies. So I just discussed few cases. My first case is a 45-year-old lady who presented with squinting of her right eye with binocular diplopia for last 1 week. She was diabetic and hypertensive, and her blood sugar showed an uncontrolled sugar levels. We could see in figure 1 that there is abduction limitation of the right eye, grading to -3. Deviation measured with prism covered test could be quantified with the left eye fixing of 30 prisms, which is the primary, and right eye fixing of 50 prisms, the secondary deviation. So secondary is more than the primary deviation. Her diplopia chart showed maximum separation in the dextro version, and it was an uncrossed image, and S chart showed a limitation of movements corresponding to the right lateral rectus. So it is a right sixth nerve palsy. So most commonly in adults, vasculopathies, trauma, and CNS lesions. Children, it is neoplasm. So need to differentiate. If for pediatric, we can follow up if it's a mono isolated lesion. Adults, you need to differentiate. If they are younger patients, go in for evaluation. Older patients, if they're non-resolving, evaluate. For bilateral, do an evaluation in pediatric and do a detailed evaluation in adults. I'm skipping the management. My second case is a lady who presented with ptosis, sudden onset, and she had an RTA 3 years ago. She had in primary gaze, she had an exotropia with hypotropia. All the gaze, she had limitation of movement except the right eye abduction was present. So his chart showed limitation, and the smaller field belonged to the right eye, and diplopia chart showed maximum separation in all the gaze except the dextroversion. So this is a right third nerve palsy. Remember, surgical management of right third nerve palsy is very challenging, and always remember not to operate more than three extraocular muscles at a time because of the problem of anterior segment ischemia. Third case, I'll go in briefly. That patient had 24-year-old male, had diplopia following RTA. After 8 months, he was presenting to us. He had a right eye hypertropia and right eye overaction. He had hypertropia of the right eye, increasing in the dextroversion and increasing in the left head tilt. Also, his Diplopia chart showed maximum separation in the dextro depression. His chart showed limitation of movement corresponding to the left eye superior oblique and overaction of the right eye. So it is a straightforward left superior oblique palsy. So always remember, in older patients, whenever they present with diplopia of recent onset, always keep congenital fourth nerve palsies in mind, because it can be rare, but decompensated fourth nerve palsies can present. Any history of trauma, always think about fourth nerve palsy, traumatic in origin. And if there is a long-standing torticollis, always think about congenital fourth nerve palsy, which could have decompensated. To conclude, remember the red flags. Whenever more than one cranial nerve deficit is present, if the pupils are involved, if you are dealing with a patient with the neurological symptoms, patient has pain with the diplopia, proptosis, always remember to take in proper detailed evaluation. Don't hesitate to take in a neurologist consult and plan in imaging whenever required, because a proper decision and proper planning of investigations can save a life, can and help us to diagnose life-threatening problems, specifically the neurological issues. Thank you so much.
Thank you, Dr. Sashikala. A very nice presentation. And just I would like to, she has added everything about the evaluation and the management aspects. So the only thing I would like to add on is, when a patient, am I audible?
Yes, ma'am.
Yeah. So when a patient presents with diplopia, first thing is to make sure whether it's a case of monocular or binocular diplopia. So unless, because sometimes we do get confused. So it's better to make sure by covering one eye and asking them whether the diplopia is still present or not. As you know, even it could be just an incipient cataract, or it could be a corneal scar, a nebular scar, which is still causing the diplopia. So first we have to rule that out. Secondly, when the vision loss in one eye is profound, like because of some retinal cause or Berlin's edema or something like that, so that causes a lot of image blur. So when the image blur is there, again, the patient is confused whether it is a diplopia or a blur. So when the blurred image superimposes on the good image, even though they are like fovea to fovea correspondence, still it appears like a diplopia. So again, we have to make sure that that is not the case. So these, apart from that, the role of prisms in managing acute onset diplopia. So I would say if the patient is able to fuse with a small face turn, then there is no need to give prism actually. So if like a very small face turn, we can still observe. And another thing is, if the patient is having torsion, like in a case of acquired fourth nerve palsy, if there is torsion, then there is no role for prism, because prism will not be able to utilize a torsional diplopia. So when you are giving ground glasses to fog one eye, in cases where the angle is too large and still it's not yet time for surgery, so it is better to fog the good eye rather than the paretic eye, because that would prevent the contracture of muscles in the paretic eye till the time when we can go ahead with surgery. And another thing is like the role of Botox till we go for surgery in a case of like an acute 6-nerve total palsy would help to prevent contracture and buy time till we decide on mostly a surgical line of management in cases where it is not resolving. So other than that, everything has been covered. So thank you, Sashikala. And the next talk, I invite Dr. Srishti, who will be giving the talk on approach to vertical strabismus today. Thank you, Srishti.
Good evening, all. Are my slides visible and am I audible?
Yeah, Srishti, yes.
I will be talking on simplified approach to vertical strabismus. Vertical strabismus is nothing but misalignment of visual axis in vertical direction. The eye which is higher up is called hypertropic, and the other eye which is lower down is called hypotropic. The muscles which are involved in vertical strabismus are two vertical recti, superior and inferior, and two obliques, superior and inferior oblique. These muscles are collectively called as cyclovertical muscles. Vertical strabismus can be congenital or acquired. It is mainly the imbalance in extraocular muscle function, may it be paretic, restrictive, overactive muscle, or there could be a developmental abnormality in the muscle itself. Coming to types, it could be committant vertical strabismus or incommittant, which can be neurologic, myogenic, restrictive, or there could be a primary overaction of the muscle itself. Dissociated vertical strabismus is another type wherein the vertical strabismus is isolated and it doesn't follow Herring's law. And the other type is the pattern strabismus, which is nothing but cyclovertical muscular abnormality, which happens in a horizontal strabismus, causing vertical deviations. How will the patient present? Patient would come up with vertical deviation or vertical diplopia, which could be associated or not with torsional component. There could be a noticeable head posture in the form of error in the presentation, like hyperopia or anisometropia, leading to a manifest DVT. You can also find a strabismic amblyopia in a child with a gross vertical strabismus. The main thing to rule out is pseudo-vertical strabismus, which would mimic a vertical deviation because of the orbital asymmetry, or there could be a displaced globe, facial-maxillary fracture, exaggerated vertical angle kappa. There could be an asymmetry in the eyelid in the form of retraction or ptosis, or a thyroid orbitopathy can also mimic a vertical strabismus. So how will we approach to vertical strabismus? The main thing is to determine whether what are the cranial nerves involved or the extraocular muscles that are involved, causing this vertical strabismus. Detailed history involving onset, the diplopia, and whether the strabismus is constant and intermittent are very important. Ocular examination includes orthotic evaluation and some special tests in case of concomitant vertical strabismus. Neurological evaluation also guides us towards pointing out the nerve palsy. Orbital UST is important in case of thyroid orbitopathy, wherein we can see the thickened muscle bellies. Imaging like CT MRI helps us to identify the thinned out muscle in case of restrictive strabismus, or we can also point out the site of lesion in case of palsies. Then reviewing old photos has always helped in a dicey situation in where the onset is not clear, and systemic diseases has to be evaluated, especially in case of thyroid is important. In ocular examination, the external examination of the lid to rule out ptosis, lid retraction, proptosis is important. Injection of the over the recti also gives us a clue. Craniofacial abnormality, facial asymmetry, and orbital dystopia have to be ruled out. Coming to abnormal head posture, this is an important sign wherein we can point out the type of muscle that is involved. For example, as you can see in the picture, the child has a predominant face turn to the left, and this is a case of Fluence retraction syndrome wherein horizontal recti is involved. And if there is a predominant chin elevation or depression, it could be vertical recti or pattern strabismus as the reason. Predominant tilt, it could be because of the obliques. Strabismus evaluation, including motor evaluation and sensory evaluation, both are equally important. And along with the detailed measurement of the deviation, the fusion capacity of the patient also is to be measured in order to prognosticate the condition. Fast test plays an important role, especially in case of esopalsy. Some special tests for concomitant strabismus, Shashikala ma'am has explained in detail. Diplopia charting mainly helpful in assessing the maximum separation of images in one of the in each of the 9 gazes, and this will help us to point out the muscle that is involved. Hess charting also, it works by Herring's and Sherrington's law, and hence it also helps us to point out the muscle that is involved. Maddox rod and double Maddox rod is important. Rod test is important to measure the amount of cyclotropia. This will help us in planning our surgery. Binocular fields of fixation is to be evaluated preoperatively, and especially it is important in case of restrictive strabismus because this improves post surgery, gives the patient a very good satisfaction. Fundus examination for torsion is also important. It will also guide us towards the diagnosis. Postduction test is another important test, helps us to distinguish between mechanical restriction and the weakness of the muscle. It is done under topical anesthesia, and using the blunt forceps, a globe is fixated at the limbus and the eye is moved against the direction of action of the muscle. This will tell us whether the muscle is tight or not, whether it is restricted or not. So coming to case examples, this is a gentleman who came with a head tilt towards the right and complained about double vision following trauma. His diplopia charting showed us vertical diplopia with maximum separation of images in right inferior position. His deviation measurement was only 8 prism diopters of hypertropia in the left eye, which increased in right case and left tilt. There was no obvious torsion and no inferior oblique overaction. Test charting also shows an evident superior oblique underaction in the left eye. So as you can see in the picture, there is no eye overaction. So just a brief introduction about the treatment algorithm for SO palsy. If the on traction test, if the tendon seems to be absent, then we have to tackle the hypertropia by weakening the IO and recessing the SR. If the tendon of the SO feels markedly lax but present, then we rather tuck the SO and weaken the IO. Or if the traction test tells us the SO tendon appears all right, we have to look whether there is an eye overaction. If there is an eye overaction, then look at the amount of hypertropia, whether it is less than 15 PD or more than 15 PD. If it is less than 15 PD, then just weaken the IO. If it is more than 15 PD, then look whether there is an SR restriction or not. If there is an SR restriction, we have to recess the SR and weaken the IO. If there is no SR restriction, then weaken the IO and recess the contralateral IR to combat the hypertropia. If there is no IO overaction at all, then if the hypertropia is smaller, like less than 15 PD, then just recess the contralateral IR. If it is more than 15 PD, then recess the contralateral IR along with ipsilateral SR. So in this patient, it was only 8 prism diopters and there was no eye overaction. Hence, in left SO paresis, right IR was recessed. This is another case where child was brought to our clinic with mother complaining of squint only when the child looks upwards. As you can see in both the photos, there is a limitation of elevation in adduction. So this is nothing but a straightforward case of Brown syndrome. Brown syndrome is because of the tight superior oblique muscle, and this has to be differentiated from IO palsy. This can be done by postduction testing, and we have to rule out whether the SO is tight or not. If there is, the tight SO is treated by lengthening the muscle tendon, and there are the list, this is the list of surgeries which are available. Fluence retraction syndrome is another case, in another condition wherein you can see vertical strabismus. This is mainly because of the leash effect of the dystrophic lateral rectus, which causes shoots. Thyroid orbitopathy is another important condition wherein you can see vertical strabismus. This is mainly because IR is the second most common muscle that is involved next to MR in thyroid orbitopathy. And this is treated by recessing the IR after the thyroid status has been come to normal. Dissociated vertical deviation is a type of deviation where you won't see a recovering movement in the other eye on cover uncover testing. As you can see in this video, the eye under cover is hypertropic, and as you when you remove the cover, it comes back to primary position. This has to be differentiated with true vertical tropia, and there is sometimes we can also see bilateral DVD, and we can also see combination of vertical tropia along with the DVD, which has to be differentiated. Another type of vertical strabismus is pattern strabismus, wherein in case of A pattern, we have to look for the variation in the amount of deviation in up gaze and down gaze to be at least 10 prism diopters to call it as A pattern. And these are the pictures of A isotropia and A exotropia. And in case of V pattern, the variation has to be at least 15 prism diopters. So in surgical planning, there is a need to measure and correct horizontal or vertical deviation along with the torsional components for better results. Prism cover test for near and distance has to be done both in horizontal and vertical directions. And torsional measurements with double Maddox rod in primary and down gaze also is very important, because in esopalsy there could be torsional diplopia mainly in down gaze. Scanning to confirm the muscle involvement helps us to plan our surgical procedure. And imaging is of a great value too. Thank you.
Thank you, Dr. Srishti. It was a nice comprehensive talk. The only thing, sometimes it may be quite difficult to judge which eye is the primarily affected eye. When you see the, especially in a case of, hello?
We can hear you, ma'am.
No, that there is something wrong with the, it's okay. The Zoom link, 1 second. Just give me a minute. Are you able to see me now?
Yes, ma'am.
Yes, ma'am.
Yes. I'll just 1 second. I'll just share my screen and I'll discuss both these talks in the end. Are you able to see my slides?
Yes, ma'am.
Yeah, just to conclude about Srishti's talk, it is sometimes difficult to find out which is the primarily affected eye initially. And so the primary and secondary deviations need to be approached with great caution. And also the 9-gaze measurements is very important, because then we know in exactly which gaze the deviations are maximum. Sometimes the primary deviation may be very less in the primary gaze, whereas in down gaze the measurements may be more. Then we'll have to think of special procedures like the Scott's procedure, where we target mainly the area where the affected eye is more. And another cause of vertical strabismus could be your traumas, the blowout fractures, where you get vertical deviations more in up gaze, and down gaze may be affected, and that's also a type of restrictive strabismus. Okay, so am I audible, right?
Yes,
I'm
ma'am.
audible. Yeah,
Yes,
yeah.
yes.
So coming to my talk is an approach to shaky eyes, or nystagmus. So what exactly is nystagmus? So it is a rhythmic biphasic oscillation of the eyes, and it's a conjugate movement. So why does nystagmus occur? Nystagmus occurs whenever there are 3 main control mechanisms which help in maintaining the steady gaze fixations. So it can be your the fixation mechanisms, the vestibulo-ocular reflex, and the neural integrator. So the fixation mechanism has both the afferent and the efferent components. The afferent is the sensory guidance to vision, and the efferent being the motor guidance. The vestibular system, which will move the eyes in response to the self-motion, so that again has both central and peripheral organs, and the neural integrator, which maintains the vision when you are looking at a moving target, which includes the saccades and the pursuits. The direction of nystagmus is defined by the direction of the foveating saccade. And mostly it is of pendular or the jerk waveforms. The frequency of nystagmus is around 17 per 10,000, not that common, but we do see quite a number of cases. And if we see the congenital forms alone, it will fall around 14 per 10,000, and the acquired causes will be around 3 per 10,000. So we need to differentiate between nystagmus versus another movement called as saccadic intrusions or oscillations, which are not true nystagmus. So how do you differentiate between these two? The difference is in the initial movement that disrupts fixation. In nystagmus, it is always a slow drift followed by a fast refixation movement. The direction of the refixation determines the direction of nystagmus. Whereas in saccadic intrusions and oscillations, it is the fast movement that moves the eyes off the target. So you have various types of saccadic intrusions that can be the square wave jerks, the macrosaccadic oscillations, and other forms. So So as you can see here, these are the square wave jerks. You have the sudden jerky movement or saccades, which are superimposed when an object is fixating on a target. So coming to the classification, the CMAS or the eye movement disorder, eye movement and strabismus, they have classified the nystagmus based on the types, the direction, and the amplitude. So based on the age of onset, you can classify them as congenital and acquired. And based on the nature of movement, it can be pendular or the jerk forms. The plane of movement can either be horizontal, vertical, or torsional. And based on the effect of fixation, it can be latent, latent, or manifest. So coming to the types of nystagmus in children, the most common form is the infantile nystagmus syndrome, INS, which was earlier called as the congenital nystagmus. Secondly, we have the fusion mole development nystagmus syndrome, FMNS, or the latent manifest latent nystagmus group. Third will be the spasmus mutans, and then the last is nystagmus secondary to either any cerebellar or vestibular or neurological causes. So coming to what is exactly the infantile nystagmus syndrome, it is an early onset nystagmus with an onset less than 6 months of age. So it is not usually seen at birth. It is an ocular pathology. So it can be, what are the reasons for this? It can either be because of various degrees of visual deprivation or the sensory reason. It can be a primarily neurological abnormality, which may or may not be associated with an ocular pathology. Or it can be an isolated inherited idiopathic oculomotor disorders. To be simple, either motor, sensory, or neurological causes. Both congenital and the latent manifest latent group are more frequent in children with periventricular leukomalacia, is a thing that you can remember. So coming to the idiopathic nystagmus syndrome, the earliest waveform is pendular. As you can see, this kid, he had a mild form of albinism, but you do see the jerk forms in the end cases, while in the center you see the pendular form. So the jerk form is usually not developed initially. It comes only by 2 years of age. The nystagmus forms can be inherited. They can have autosomal dominant, recessive, or sporadic ways of inheritance. But the thing to remember is this: these nystagmus is always horizontal. Even in vertical gaze, it continues to be horizontal. INS has a null point, and the null point is usually within 10 degrees of fixation. It happens with convergence. That is why we get the fusion nystagmus blockade. It exacerbates with fixation. So when we ask them to read monocular vision, the visual acuity drops, and there is no oscillopsia because it is at birth. There is a compensatory mechanism, and the patient do not complain of oscillopsia. If there is a complaint of oscillopsia, it is not a inherited or it's not a congenital form. So idiopathic infantile nystagmus associated with a null zone. This is the way we measure the nystagmus, the head posture. The patient, because of the head posture, the patient tries to maintain the null position with the fixation on the object of regard. So it can be measured by a simple goniometer, as is being done here, where you just align the primary, and then you see the tip of the nose and you align the other and just measure the angle. And there are various other ways of measuring head posture also, including the CROM type of instruments. And you can measure both in the face turn, the head tilt, and also the chin elevation or depression. So why the patients adopt the AHP is because they want to shift the null zone from the eccentric position to the primary position. And that is also, they get better vision with the null zone. So decreased vision and nystagmus, or a sensory deficit nystagmus, is due to disorders of afferent visual pathway. This is a severe case of sensory nystagmus due to oculocutaneous albinism. You can see in all cases of nystagmus, you need to look for iris trans-illumination defects, because sometimes the albinism will be very subtle and you'll be able to pick up only the trans-illumination defects. This is a patient who had aniridia with just a small iris stump, and there again you get the pendular waveforms. And this is a child, the third one is a child with a congenital cataract. In congenital cataract also you do get nystagmus when the treatment is delayed. So it is always better to operate and on the cataract and give corrective refractive correction in terms of glasses or IOL before the onset of nystagmus. So again, this is a eye with a microphthalmos with a coloboma, where left eye there is a total loss of vision and right eye is microphthalmic with nystagmus. And this child has born with Leber's congenital amaurosis, where you can see this is not exactly nystagmus, it's a roving and searching kind of movement which you can see in very profound vision loss. That's called a roving movement. So coming to FMNS, so here in this video, you can see the child who has a large isotropia. So this is actually a isotropia that the child is adopting to block the nystagmus, because the nystagmus reduces with convergence. So why does this happen? It's because of asymmetric sensory or motor deficit. Usually this is FMNS is associated with strabismus, especially isotropia. And the thing is, it is not visible when both the eyes are open, but you can see it only when one eye is being occluded, and the direction of the nystagmus is towards the fixating eye. And Nystagmus blockade is a special form, which I have already told, that is to dampen the nystagmus in order to convert it into a low amplitude FMN. So this is a Spasmus-Newton syndrome where the onset is more than 6 months of age and prior to 2 to 3 years of age. So it is a triad of nystagmus with head nodding and anomalous head posture, that is called torticollis. And the good thing is it resolves by 5 years. But you always have to do a neuroimaging, because rarely it can be because of a chiasmal glioma. So if the chiasmal glioma is not there and the MRI is clean, you can reassure the parents. Most often times it resolves by 5 years. An important thing to remember is the periodic alternating nystagmus. When you're seeing a patient of nystagmus, it's always better to observe the patient for a minimum period of 5 minutes so that you don't miss this condition. It's an unusual congenital motor jerk nystagmus with a 60 to 90 second one-sided jerk, and then there is no nystagmus, and then there is a nystagmus in the opposite direction. Usually there are 2 null positions. So the thing is, if you operate for one AHP, then the patient can adopt the other null after surgery. So it is better to treat it medically with medications like baclofen, and the surgery is, the surgical procedure is different. It is recession of all 4 horizontal recti, not a modified Anderson's procedure. So functional implications are, because of sensory associations, and even in motor nystagmus, you can have little poor vision, and the reading speed is very much decreased. There has been studies where the patients with nystagmus are shown to have around a 30% reduction in the reading speed as compared to the normal children of their age group. And that leads to, and even it's a very visible thing, you cannot hide that they have a problem. So they have poor self-esteem and increased dependency. So you have to take a thorough history with the age of onset, the birth and developmental history, family history of nystagmus, any photophobia, any other neurological abnormalities, history of oscillopsia, or any medication intake, because recent onset of certain medications can also induce nystagmus. And assessment of the child's vision behavior. You have to document the vision in all cases whenever possible. And when you are doing a monocular vision, you don't put the cover, you just do a fogging so that you don't degrade the vision in the other eye. Measure the anomalous head posture, characterize the nystagmus with the type, amplitude, direction, null point. Then if there is strabismus associated, we need to measure the strabismus. Other tests like color vision, anterior segment, transillumination defects, paradoxical pupils are seen in some retinal anomalies, red reflex, fundus evaluation, and in acquired nystagmus, neurological is very important. And then ERG and VEP for diagnostic purposes, and OCT can also be contemplated to assess the macula. So is it very essential to record the nystagmus? If you have the if there is a possibility, then it is good to record, because you can document and detailed review the monocular versus binocular nystagmus, direction of movement, the frequency, slow phase, and null point can be all very well seen. So you need to know when you are recording that what is the meaning of foveation period. So foveation period is the brief amounts of time when the eyes are moving with a sufficiently slow velocity whenever the visual axis is near the target. So when you are recording a nystagmus, there are 2 ways of measuring the visual acuity. So that is something called as a NAFX score. The NAFX score will directly correspond to the vision potential of that patient. So it is an expanded nystagmus acuity function, and this has been developed by Deso and colleagues. And the other thing which closely corresponds to the NAFX score is the NOF, which can be done in children, because for NAFIX you need to have a head very still with the chin rest. It may not be possible in small children. So NOF actually corrects for the movement of the child, and the child need not maintain a steady head posture while recording to measure the NOF values. So there are 12 different waveforms, from pure jerk to pure pendular, with varying forms in between. As you can see here, this is the position recording, and this is the velocity. And this part where you can see a very less movement is actually the part of foveation, where the velocity is also the minimum. So how do you record this? Is by the limbus reflection goggle systems, where you look at a red target or some target which the child can see. And also it can be done by remote video tracker with a camera whenever the goggles will not be worn, especially small children. So the fixation stimuli is presented with targets in a dim room. And for able children, you can use the head support and the chin rest. So you see here, this is a Nystagmus recording, where this is a right gaze, where you can see that the waveforms are quite, you can see the Nystagmus movements quite marked. Primary position is less, where in the left gaze, the movements very less, so which is corresponding to the null zone. So you can have a documentation of this before you do the surgery. And here we can see two null zones, which is actually the convergence null. So if you see convergence null, those patients can benefit by either you can give base out prisms on both eyes, or you can contemplate on an artificial divergence surgery. So coming to neuroimaging, any sudden onset nystagmus, infant who presents with any atypical form like asymmetric monocular, associations with optic nerve hypoplasias or optic atrophies, gliomas, craniopharyngiomas can be presenting with nystagmus or even associated hydrocephalus. Sometimes even life-threatening disorders like retinoblastomas, septo-optic dysplasias and all can present with nystagmus. So always better to do an neuroimaging whenever you have a suspicion. The aim of management is to stabilize the eyes, to improve the vision, to decrease the oscillopsia, or to shift the null zone towards the primary position. So these are the aims of surgery. So the non-surgical management, like if there is
Dr. Sandra, we are not able to listen to you correctly. Can other doctors confirm?
Convergence, if you can the nystagmus in most
Yes, the voice is not clear,
cases.
ma'am.
Soft contact lenses will clear us and improve the nystagmus. Okay.
I think there is some network issue. That is why Dr. Sandra is not there in the session now. I think she'll log in some time.
Yeah, just give a few minutes. I think she'll log in.
Sure. I'll just call her up to know what the issue is.
Sure, okay. I'm just calling her up. Just wait for a couple of minutes when she reconnects. Thank you so much.
Yeah, I think Dr. Sandra is here now.
Yeah. Am I audible now?
Yes, ma'am, you are audible now.
Right. I'm sorry about the internet issue.
No problem, ma'am.
Yeah, are you able to see my screen?
Yes, ma'am, it is visible.
Yes, ma'am.
the soft contact lens, were you able to listen like till when?
Ma'am, till your previous slide, we were able to see. Yeah, the aim.
Right.
Yeah, yes, ma'am. Till this, we were able to listen. Yes, ma'am.
Just continue from here. Yeah. So the aim is to stabilize the eyes to improve the visual acuity, decrease oscillopsia, or to shift the null zone towards the position. And management, you can give either base-out prisms, contact lenses, drugs, or Botox. Surgical management procedure for the head tilt, you can operate obliques or transposition of recti, and chin elevation or depression. Again, you can do recession of vertical recti. So coming to the surgical management, decreasing nystagmus intensity can be done by artificial divergence, maximal recession of all horizontal recti.
Ma'am, your PPT is not visible.
Yeah, then suddenly my internet connections is a bit bad. I'll just finish it up. It's just another 2-3 slides.
Sure, ma'am.
Yeah. So I'll just like to share the clinical evaluation of Anderson's procedure that we did in a study of around 17 patients, where 37 patients between Jan 2014 to 2017, where the mean AHP with the augmented Anderson improved from 22.5 degrees preoperatively to 7.58 degrees at 1 month post-operative visit. So, and also this was associated with an improvement in the visual acuity also. And but when you are faced with a situation like a complex head posture, then you may have like problems having combination of face turn, chin elevation or depression, and head tilt, or a combination of these. So this is a patient who came to us with like a 10-year-old with a anomalous head posture, and she had a right face turn, a right head tilt, and a chin elevation of 10 degrees. And but there was no associated strabismus. Her visual acuity was very good in the levo depression. So rest of her ocular exam is normal. So to correct the horizontal, the right face turn, we operated on the right medial rectus and the left lateral rectus recessions, which is an augmented Anderson procedure, along with the rotatory Kestenbaum procedure, where you shift the vertical recti, like the right inferior rectus alone we had transposed with the left temporally with the left eye nasal transposition of the inferior rectus with the recession. So this was a pre-op and the post-operative head postures following the rotatory Kestenbaum. So what exactly is rotatory Kestenbaum? So we have to remember that when there is a head tilt, the same side is incyclotorted and the opposite side is excyclotorted. So that is similar to having a superior oblique overaction and IO underaction on the same side, and SR overaction and IR underaction on the same side, and vice versa on the opposite side. So we have to extort the eye on the same side and intort the eye on the opposite side. So this can be done by surgery on the obliques or recti. So we have to weaken the superior oblique and strengthen the inferior oblique ipsilateral. And if you want to operate on recti, we have to nasally transpose superior rectus and temporally transpose inferior rectus, and vice versa on the opposite side. So because of this management, which I have already told. So in this patient, we did only the inferior recti because we didn't want to operate on 3 recti muscles. And also associated chin elevation was there, so we did it along with the recession. So thank you.
So yes, we can take up some questions and we can have a discussion on the same.
Yes. Is there any questions coming from the panel? Yeah, there is a question by Dr. Laila Mohan on chat, and she's asking, what is your experience with topical brinzolamide? Actually, madam, we have not used that many patients. Very few patients we have used actually topical brinzolamide. So personal experience is very less in this regard, but it has been told that it's quite a useful drug which can be tried. Only good thing is it's topical, not a systemic drug, so the chances of other side effects are very less.
Have we taken one more question by Dr. Kavita Purwal?
Yes. What is the question?
I'll just post it in the chat.
About your opinion about seesaw nystagmus, question from Dr. Kavita Purwal.
Okay, I think Dr. Amrita, would you like to answer this question? Because she's the seeing the neurology here. Seesaw nystagmus is not that very commonly seen, and we usually do not. Seesaw nystagmus, we don't usually do any surgical procedures for nystagmus from a strabismologist point of view. Though from a neurology point of view, Dr. Amrita, would you like to add something?
Seesaw nystagmus, although uncommon, it is one of the sign of any chiasmal lesions. So neuroimaging is warranted in all cases of seesaw nystagmus. As far as surgical concerned, I think I've not seen any surgical intervention being done for the seesaw nystagmus.
Yes, and another question from Dr. Kavita, what is the dosage of brinzolamide you are using and for how long? Brinzolamide usually applied once a day, can be applied for 3 months, and if the initial review is after around a period of 2 to 3 months to see if there is any subjective improvement in the nystagmus that the patient is perceiving. We don't have nystagmus recording here in Coimbatore, so objective measurements we are unable to get. Yeah, thank you.
I request the audience to write up the questions if you have any for the panelists.
Oftentimes, mostly, any more questions are there?
No, ma'am, we can have some discussion if you want. We still have 5-8 minutes.
Okay. Just when we approach vertical strabismus, so I would like to say a few words on superior oblique palsy management. So when we see a case of congenital superior oblique palsy, they have very good fusion amplitudes. So it is always better to undercorrect these patients when we do a superior oblique tuck or a tuck procedure when we combine them with inferior oblique recession. Because if we aim for the full amount of deviation that we are seeing, the patients usually have a reversal and they will not be able to tolerate a reversal. But if we are facing a case of acquired superior oblique palsy, then we may have to correct it fully because they don't have any vertical fusion. They have very less of vertical fusion amplitudes. So that is one thing which I would like to share. And basically, the Hess charting and Diplopia charting are very important from the prognostic point of view because that helps us to follow up these patients and look for the muscle sequelae. And then our surgery is usually based on what we see. Even in a case of SO palsy, there can be superior rectus contracture, which we need to document. And if it is so, then our surgical choice of muscles vary. Like if there is superior rectus contracture, then we'll have to definitely recess the superior rectus. So whenever the postduction test is tight on any muscle, then definitely that muscle would have to be weakened, though by a smaller degree, because otherwise it can result in overcorrections. So whenever we are not sure of the values, it is always better to put these patients on an adjustable suture so that we can see it the next day, and then we can put the knot wherever we want it to. Another thing is it is always better to do the 9-gaze measurements that I have already said and target the areas where the deviation is maximum. Any other thing, Dr. Sashikala, would you like to add any more points, or is it time to give the hall, or we still have time?
All the points were very
some time.
All the points are very well covered, ma'am. It was a nice session. I thank all the speakers also for being on time and able to complete it.
Yes, so then we would like to hand over. Thank you, AIOC, for arranging this virtual meeting. Very nice arrangement, and thank you very much for this opportunity.
Thank you very much, all the speakers. It was indeed very insightful to listen